think, let me mute. I'll give you an introduction and then I'll mute myself.
Oh, yeah. So you can see my PowerPoint, is that correct?
Yes, I can see your PowerPoint, yes.
Yeah. Thank you.
Yes, I can. Give me yeah, perfect. And we're live. So, perfect. And we're live. So good evening, everyone. Welcome to our first Mind the Bleep tutorial for the ophthalmology section. So we're joined here by Dr. Peng Sim, who is an ST4 ophthalmology registrar at North Thames Deanery for ophthalmology, and he's currently working at Imperial College Healthcare Trust. And I'll give him the lead.
Okay, yeah, thank you, Soma. Thank you very much, Soma. Yeah, thanks for giving me the opportunity to do this talk today. So I think the aim of today's talk is just to really give you a brief overview and also a flavor of ophthalmology. We don't really expect that much from foundation year, and we are really friendly people, so you can always come and ask us any questions. Yeah. So just to give you an outline of the talk today. We'll just first go through some basic clinical assessment of vision and also the external eye. We will then go through some common eye symptoms and conditions, and I will be doing this by taking you through a few validated diagnostic algorithms, which you should hopefully find helpful. And I'll try to pitch everything at a level expected of a foundation year, especially when making a referral to ophthalmology. And feel free, I think there's a chat function here, so feel free to just post any questions. And also I'll try to make this quite interactive as well. So whenever, if I ask any questions, just feel free to just type in anything in the chat box and I'll check it regularly, okay? Yep, so the aim, again, is really to, like I said, give you a better framework so that you hopefully can equip you with more confidence when dealing with eye conditions. And by the end of this, I hope most of you feel much more comfortable with basic ophthalmic history taking and examination, and also just feel a bit more confident when you're speaking and referring to ophthalmology. Okay, so we'll start with clinical assessment. I thought it would be just good to do a retrospective. I know everything in medicine, we should always start with history taking, but I think it's just good to start, do a retrospective approach and start from clinical assessment first. So with ophthalmology, actually, it's pretty simple. We are not looking for much. And every time you speak to us, all we want to know is really, just the 5 functions of the optic nerve. So can anyone name a few in the chat? Yeah. No? Okay. So the optic nerve function conveniently can be remembered as the mnemonic afro-C. So A is for acuity, and then next letter F is for visual fields, R is for pupil reflex, O is the dreaded ophthalmoscopy, which in real life we don't really expect you to do, and C is color vision. So we'll go through each of them one by one in more detail so that you're aware. So acuity, so we normally do this, at least in the eye clinic, using a Snellen chart. So this is a Snellen chart on the left, and the way we record it and the way we conventionally do it is we normally sit the patient 6 meters away from the chart, and hence the first number at the top being 6. And in ophthalmology, every test that we do, we always do one eye at a time, never both eyes together. So if there's something to take away from this talk, is that when you test some, it doesn't matter what you test, vision, pupil reflex, color vision, you always do one eye at a time. And then you get the patient to read, from the the biggest letter all the way down to the smallest letter, and you record the lowest line that they can read. So in this case, so if this patient can read this line, I'm not sure if you can see my mouse hovering around that line there. So this line would be, if there's a number there saying 12. So if this patient can read this line, you record it as 612. So 6 being the numerator, being the test distance, so how far the patient is sitting away from the chart, and 12 being that line that the patient can read. Okay. And the thing to bear in mind as well is that if the patient does not achieve 6.6, which is considered, normal vision, then you must always repeat it with a pinhole. And a good tip is that the larger the denominator, the lower number, the worse the vision. Okay. Yeah. Any questions at this point? No. Okay. So I'll just take you through some examples here. So say in this case, say if I'm the patient and I'm testing my own left eye, if I can read down to this line here, I'll record this as 6:15. Yeah. And the other thing to bear in mind is that when you test someone's vision, it should always be optimized. So if the patient wears glasses or contact lenses, you must always ensure that the patient is, optimized, because we want to know what the best visual potential is for the patient. So always check with the patient whether they wear any corrective glasses or contact lenses. So in this case, as we've mentioned already in the previous slide, because this patient is not achieving 6.6 vision or normal vision, we have to repeat it with a pinhole. Okay? So a pinhole is what you can see here, and this patient is holding it in front of his left eye, and then we test the vision again. So after using the pinhole, this patient's vision, let's see here, improves to 6.9. And so we record that as 6.9, and the word here OS refers to, is actually the Latin word for left eye, it's oculus sinister. So with the pinhole, the patient improves. So when this happens, when you get an improvement of pinhole, then it's a sign that this patient has a refractive error, and it's kind of like a triage tool for us in ophthalmology. So if we see an improvement with pinhole, we are actually really reassured that this patient doesn't have a serious problem, and actually this patient just needs his or her glasses updated. Yeah. So the diagnosis here is likely to be a refractive error. Okay. So the next case, again, one last example for visual acuity. So this time I'm testing, say, this is another patient, testing using his right eye. And as you can see here, the lowest line that you can read is 6:20. So we'll record this. And also, I think this patient, if I'm not mistaken, also wears glasses or contact lenses? Glasses, yeah. So glasses. So in this case, again, you must make sure that the patient's vision is optimized. So you record this as right eye, OD being oculus dexter, Latin for right eye, with glasses and 6:20. Again, because it's not achieving 6.6, so you will repeat this with pinhole. Here, pinhole over the right eye, and then repeat the visual acuity again. So in this case, with the pinhole, he gets an extra 2 letters. So then you would record this as right eye, OD with pinhole, 6:15 minus 2. The reason we put minus 2 there is because on that 6:15 line, he's not able to read 2 of the letters there. So you would write it as 6:15 minus 2. Yeah. So in this scenario, actually, with the pinhole, the vision actually doesn't improve that much. It only improves by 2 letters. So when this happens, then you are fairly certain that there is an organic pathology. And in this case, it's to do with the retinal optic nerve. So just summary point again. So if the vision doesn't improve with pinhole, then you're more worried that there is an underlying pathology. If it improves drastically with pinhole, then you know it's likely to be just a refractive error. Okay. So I think in real life, obviously, usually Snellen charts are nowhere to be found. Obviously, so a good app really that I would recommend, and also actually it's recommended by quite a lot of my colleagues, is this app which you can get for free on Apple or Android, and it's called MD Calc. It's got a really cool and easy to use Snellen chart, which you just hold sort of 1 meter away from the patient, and conveniently enough, you just ask the patient to read, and then you just select the line that the patient can read, and then it'll tell you what the patient's vision is. And then, yeah, and if you communicate this to us over the phone, we'll be over the moon. Yeah, because usually when we ask for visual acuity, people just say, patient can't see, or patient can, read, just read a book or something. Yeah, but giving us absolute numbers will be much more useful. So going on to the second visual function, which is visual field. So in reality, again, there's many ways of doing this. There's definitely no best way of doing it. I would say just do whatever feels comfortable for you. Some people like the wiggling finger technique, and some people like to ask, how many fingers you can count in each quadrant. So and then some people like to bring their hands sort of gradually vertically and also horizontally. As in this picture, always bear in mind the imaginarily vertical meridian and also horizontal meridian. So I think a systematic way of doing it is always start off with a gross assessment. So you can easily pick up any obvious defect there. Just ask the patient, to just close one eye and say, can you see, my face? Is there any bits that are missing? If they're telling you that half the face is missing, then then it's likely that there is a sort of potentially a homonymous hemianopia. If there is no gross defect, then proceed with examining the peripheral vision in more depth. Again, always making sure that you test one at a time, and then when you do it, make sure you're at the same level of the patient, and then the target can be a red pin or your fingers. Make sure that's equal distance between you and the patient. And then we'll go through. Okay, so we've just done that. So we'll go through some examples here. It'd be good if you guys could, chip in, and because so on our left, you can see some, visual field defects. Imagine these are your own visual fields that you're staring at the screen, your left being your left and the right here being your right. Can anyone name, what sort of visual field defect there is in the first picture, this one here? Anyone? Yeah, Hester, absolutely right. Yeah, do you know which side that is missing? Left side, correct. Yeah. So left side. So when so the good thing about visual field is that you can easily localize where the lesion is. So as you rightly said, this is a left total field loss. And usually when it's monocular, so it's only the left side. So when you're faced with a monocular visual field defect, you can be 100% certain that the problem is anterior to the optic chiasm. So anything in front of the optic chiasm, so anything in front of, I'm not sure if you can still see my mouse here, anything in front of number 2 here, from the cornea at the very front, all the way back to the optic nerve, any problem along this pathway will give you a monocular visual field defect. So you're absolutely right. So the first one is a left optic nerve problem. And the second one, does anyone want to volunteer and tell me what the second visual field defect is? Oh, perfect. Yeah, so it's a bilateral hemianopia. And Jonah has a guess as to where the lesion is. The clue is here. It's in number 2. Okay, so yes, perfect. Yeah, so it's in the optic chiasm. Yeah, not a lot of pathology will give you a bitemporal hemianopia. So when you see this in real life, the first thing you need to do is think about a pituitary lesion. Usually it's a pituitary adenoma. And the most sensitive scan to pick up any lesion in the pituitary area is an MRI of the base of the skull. So that's good. So we know that's the optic chiasm issue here. And the last one, number 3, can anyone yeah, you're right, Jomana. Yeah, absolutely correct. Yeah, so it's a pituitary adenoma, pituitary tumor. So number 3, visual field defect. Can anyone just say what that is? Sorry, oops, I showed the answer there. But can anyone name what the visual field defect is? So I'm just going to have a look at the chat here and see if anyone volunteers. No? Okay, so this here is a right-sided homonymous hemianopia. So when the right side is affected, then because everything in the eye is opposite, so if the right is affected, then you would expect the lesion to be on the left side. So in this case, it would be the left optic tract or the left visual cortex. So it'll be this side here. Okay. So next will be pupil reflex. There's not much to say about this really, but it's important to do this properly. I think a lot of people, tend to just sort of do this briefly when examining people. And actually, there's a lot of information to get by examining someone's pupil reflex. So key tips in doing this, I always tell people you must make sure that you try to dim the room light, to make sure that the pupils are as dilated as they can be. Get the patient to look far. The reason for this is because if they look near, they get this near response where the eyes sort of converge and then constrict. So that can interfere with your interpretation of that patient's pupil reflex. And then also, again, in order to minimize the near reflex, I like to shine the light from the pen torch from the bottom. So not straight in front of the patient, but from the bottom, sort of from the nose area. And then when you are doing the swinging light test, you have to do it swiftly and consistently. So do it in sort of a regular sort of rhythm. Okay, so the reason I'm showing you this complex picture here, you don't have to know any of this, but the reason I'm showing you this diagram is so that you can appreciate that there is a bilateral innervation of the Edinger-Westphal nucleus by the sensory pathway, which is shown in yellow here. Because of this bilateral innervation, that is the reason why when you shine light in one pupil, so if you shine light here, it goes all the way here, but then it innervates both Edinger-Westphal, and then it sends motor impulses to both pupils to constrict. So that's the reason when you shine light in one eye, both eyes constrict. And this is mediated by the parasympathetic pathway through the sphincter pupillae, which you can see in the middle here. So remember, that's parasympathetic pathway. The clinical relevance is that is seen when there is parasympathetic disturbance. So in a third nerve palsy, remember the pupil cannot constrict and therefore becomes dilated. Okay. So now bearing in mind, so here, let's imagine this is a patient. So you always pupil reflex is straightforward. So what you do is that you just test the direct reflex in the eye that you are shining the light in. So in this case, we're shining the light in the patient's left eye. So you can see a direct reflex present in the left eye. And when you're doing this, it's important to look at the fellow eye. So in this case, you can see that the right eye is also constricting. So you would also comment that the consensual reflex of the right eye is also present, which is good. Once you're happy that both direct and consensual reflexes are present, then you would then proceed to do the swinging torch test. And that's to test for relative afferent pupillary defect. So, and in this last, so I've just mentioned that already. So in the last picture, so you can see that when the pen torch is swung over to the right side, instead of that eye constricting, what happens is that eye is now starting to dilate. So when that happens, when the eye paradoxically dilates when it's being shown, then you would say that there is a RAPD present in that eye. Okay. Any questions so far? Okay. And things that can give you an RAPD are just, again, some clinical relevance here. Things that can give RAPD are not that many things really. One is obviously any sort of optic nerve problem. Classically, we get patients here with optic neuritis in the context of multiple sclerosis. And typically you get quite a dense RAPD. And other pathologies that can give RAPDs. So it's either optic nerve or the retina, especially if it's a widespread retinal issue, like a big retinal detachment or a vein occlusion. Yeah. So that's pupil reflex. So if you see one, always think. If you see RAPD, always think optic nerve or widespread retinal problems. Okay. Yeah. So next. So ophthalmoscopy, I'm not really going to say much about this because in real life, there's many hurdles to doing this, as I've come to appreciate after doing foundation year myself. So the reality of direct ophthalmoscopy, number one is, it's usually nowhere to be found. And even if you need it, and if you really have to do it, just try your best. But be reassured that, we will, you'll be forgiven if you cannot get a view. Yeah, because even some of my colleagues, even myself, sometimes we struggle. Yeah. And from a practical point of view, in a non-ophthalmology setting, I believe the direct ophthalmoscopy is only really useful for its blue filter, which you can easily find. And you can combine this with fluorescein drops that you can easily find in A&E. And it can help you identify any corneal problems. So you can see in the picture here on bottom right, you can see just with normal illumination, the cornea looks pretty normal. But once you put a drop of fluorescein, which is usually orange, and then you use the blue filter on the direct ophthalmoscope and shine it on the eye, you can see that there's clearly a corneal sort of epithelial defect there. So it's really handy in this case. Also, the direct ophthalmoscopy is also really good in detecting whether or not a red reflex is present, and you just have to hold the direct ophthalmoscope and view the patient's eye from quite far away, and you can easily check. So on the diagram on the right here, so the first picture here, obviously it's already annotated saying normal reflex, and the bottom two are abnormal, so red reflexes. When you see an abnormal red reflexes, it tells you that there is some sort of opacity of the ocular media. It can be either the cornea from the very front, the lens in the middle, or the retina or vitreous at the back. So typically, things like cataract, vitreous hemorrhage, retinal detachment can cause an abnormal red reflex. So if you see that, then you know that there is likely to be a problem that needs to be dealt by ophthalmology. So yeah, so don't worry about doing this in real life. Yeah. I mean, if you have to do it, here are some key tips. So again, like testing for pupil reflex, always use a dim light. Again, the reason for this is you want the eye to be, as fully dilated as possible. And then again, get the patient to focus on on something far, because again, if they look at something near, they get that near response where the pupil constricts, and they just, and you just struggle to get a view. Ensure that you are at the same sort of level as the patient. And it's important also, to tell the patient to breathe normally. It's important for you and the patient, because otherwise, if you're holding your breath, you might just pass out when you're doing the direct ophthalmoscopy. Always use the circular white light to begin with. And there's lots of numbers on the direct ophthalmoscope, but I tell people just set it to 0, because that just eliminates sort of any refractive error to begin with. And then you can either dial the number up or dial the number down to get a clearer view when you go into to see the fundus. Yeah. So basic things here. So when you're checking someone's right eye, you use your right hand and then do it the other way around when you're examining the left eye. Because otherwise, if you use your right eye to examine your right hand to examine someone's left eye, you might end up kissing them. Yeah. So in real life, I'm just showing this diagram here because, again, this is one of the many reasons why direct ophthalmoscopy is not really that useful, because the photo on the left is, a classic fundus photograph that you would get in textbooks, nice wide view, including the disc and the macula. Whereas in direct ophthalmoscope, you just get that really sad, magnified view on the right, which you can't even barely see, you can't even see the whole disc. And you sort of have to build a mental picture by piecing up the images as you go along. So, at the end of the day, just try your best and don't worry if you can't get a view. Okay. Okay, so lastly, just touch on color vision here. This is not much to be said about this. Really, a brief screening tool would be the red head pin, which, again, if there's any sort of color vision defect, usually that points to a problem with the optic nerve. Again, as mentioned before, classically we see that with optic nerve pathology like optic neuritis in MS. And then on the right here, I've just shown you Ishihara plates because this is the formal way we do it in the eye clinic. And actually, if you could, if you're making referrals, well, we would really appreciate it if you could tell us what the color vision is in terms of the number of plates that the patient can read. And again, the app that I was just recommending previously, MD Calc here, is really good and has a really, really easy to use Ishihara test. So that brings, so I think that's a brief summary of clinical assessment. So remember, the things to look out for is easy. So just the 5 sort of functions of the optic nerve. Remember the mnemonic F-R-O-C, A for acuity, F for feel, R for reflex, O for ophthalmoscopy, just forget about that, and C for color vision. Yeah? These are the core information that we are looking for ourselves when we assess a patient, and also when taking a referral. So as long as you mention these, you will make us very, very happy, and we cannot, essentially, you cannot reject your referral. Okay. Okay. Any questions so far? No? Okay. So now I think for the second half of the talk, I'm just going to take you through, like I said, some common eye symptoms, and as I think it's more realistic as patients present with symptoms rather than coming in with a label and telling you what their condition is. So over the next few slides, I'll give you and be sharing with you some validated diagnostic algorithms that will help you arrive at different eye diagnoses depending on the different features and signs. So can anyone tell me what are the most common eye symptoms? You probably will have encountered this yourself if you've done any or are doing any at the moment. Can anyone just type a few in the chat box? Yeah. Oh, sorry. Yes, so I can see blurry vision, pain, floaters, conjunctivitis, visual loss, red eye. Yes, so this is, yeah, that's pretty much it. Yeah, so you're all absolutely right. So in fact, the most commonly encountered eye scenarios are, red eyes, as you rightly said, vision loss, double vision. Another couple less encountered ones are like watery eyes and isochoria, where the pupil sizes are different, and there's many other symptoms. But I think given that statistically these are the most common ones, so we will be concentrating on them today in the interest of time. And what I'll be going through the next few slides again are the diagnostic algorithms. So you can use them as a systematic framework, which will hopefully help to differentiate the common eye symptoms you see in everyday practice, especially in A&E or GP. So we'll start with red eye. Okay, so there you go. So with the red eye algorithm, the first question I usually like to ask myself is, is this, again, in ophthalmology, we are obsessed with this thing where whether it's one eye or both eyes. So the first question I ask myself is, is it unilateral or bilateral? So that's the first question. So if we concentrate on, bilateral to start off with, so the way I break it up is, I ask the question. The next question is whether or not the predominant symptom is itch, or whether it's sort of grittiness or burning. So if it's predominantly itchy, sort of what sort of conditions might you be thinking about? So bilateral itchy eyes. What do you think that might be? Yeah. If anyone could hazard a guess on the chat box, yeah. Yes, conjunctivitis, that's correct. Yeah. If I'm being a bit mean here, Hester, because there are different types of conjunctivitis. So if it's predominantly itchy, do you know what kind of conjunctivitis that it's more likely to be? Yes, viral can definitely make the eyes really itchy as well. Allergic, yeah, allergic is the correct answer here. So if it's predominantly itchy, so then we always think about allergic conjunctivitis. Often these patients will have a history of atopy, asthma, hay fever, and eczema. They're just just generally very allergic. Yeah. And in the photos here, you can see that on the left, the eye is obviously very injected. Injected is just another way of how we describe a red eye. And also the conjunctiva there is very swollen or chemos. So typically you see that in allergic conjunctivitis. And on the picture on the right there, this is with the upper lid everted, so turned inside out. And you can see this classic sort of cobblestone papillae, where you would only see in allergic conjunctivitis. Yeah. So going back, so if it's bilateral and now the predominant symptom is gritty or burning. So I think I just looking at the chat again. Someone said viral conjunctivitis. Yeah. So Dean, you'll be right here in saying that this is viral conjunctivitis. And then the next question to help differentiate, because there are also different types of infective conjunctivitis. It can be viral, it can be bacterial. So a good way is to ask whether there's to check whether or not there's any sort of discharge. And if there is discharge, usually it's mucoid or mucopurulent, then you would think about an infective type of conjunctivitis, either viral or bacterial. In real life, it's hard to tell between the two. So if you see a case like this where both eyes are sticky and red, it's better to always treat the patient with some antibiotics like chloramphenicol drops, because that would just cover if there is a bacterial element to it. But in most cases, in more than 90% of cases, it's usually a virus, and it would resolve without any treatment. And if there is no discharge present here, then usually you can it's usually just the eyes being a bit dry, causing a bit of irritation. Yeah. So as you can see here, under the bilateral red eye pathway, all the final diagnoses are actually labeled in green. So actually they are sort of fairly reassuring. And the thing about to say about in ophthalmology is that if the problem is in both eyes, we're usually quite reassured, and the problem is usually non-urgent. If it's one eye, then usually we get quite worked up. Yeah. So I think I will now go on to the unilateral pathway, so the single red eye. Okay. So there we go. So the red eye, when one eye is red, the good tip to start is that you should always start with the from the outside and always look at the eyelids. So the question I put here is that to check whether or not the lashes are touching the eyes, because if there's an obvious sort of misdirected eyelash, then that's obviously the problem. So some diagnoses such as entropion and trichiasis, they're not often seen, but it's good to just be aware that there are, that they exist. So entropion here on the left, as you can see, entropion refers to when the eyelid is inturning, and whereas the cousin of it is called ectropion, EC, where the eyelid is turning outwards. So in entropion, you can see when the eyelid is turning in, the eyelashes are obviously scrubbing against the inside of the eye and therefore causing irritation and redness. And the picture on the right here is a picture of trichiasis. So the difference between trichiasis and entropion is that in trichiasis, there is no abnormality of the eyelid itself. The abnormality here is just with the eyelashes themselves. So there's just misdirected growth of the eyelash. Usually, this is a result of, badly done lid surgery or from some previous trauma. So if you're happy that there is no lashes touching the eyes, then the next question to ask is, whether or not there's normal eyelid closure. Can anyone think of any condition where the eyelids might not be able to close fully? I'll give you a hint. It affects one of the cranial nerves. Yeah. Yes, perfect. Yeah. So it will be Bell's palsy. Very good, Dean. So there you go. So if always ask the patient, to try to fully close their eyes, and obviously if they can't, if there is, what we call leg ophthalmos, where the eye doesn't fully shut, as you can see here in the patient's left eye, then that can be a cause for redness as well, because the eye is exposed, and then and due to a poor tear film, the front of the eye starts to break down. And if there is normal eyelid closure, then you start looking at the eyeball itself. So the golden rule in ophthalmology, and indeed in GP and A&E, is that anybody with a one-sided red eye or unilateral red eye should always be given fluorescein eye drops. Because the reason for this is because even if the cornea, I think if you remember from one of my previous slides, because even if the cornea appears normal, by applying fluorescein, you might be able to find some issues with the cornea. Such as like a corneal abrasion or corneal ulcer. So then the next thing is to see whether or not the corneal stain. So this picture here demonstrates nicely that even to the naked eye, the cornea looks normal, but once you put fluorescein in, you can see that there's actually quite a lot of staining, showing that there is a corneal ulcer here. Okay. So once the corneal stains, the next thing is then to just look at how the cornea itself looks. So if it looks, grossly opaque, then that that multiple layers of the cornea is involved, and that usually indicates a more serious corneal issue, which would warrant urgent referral to ophthalmology. So in this case, you can see the eye is obviously white and opaque. You can't even see the iris behind the cornea. And that's because it's involving multiple layers of the cornea here, involving the stroma, which is the middle layer of the cornea. So you get this haze around the cornea. If the cornea looks fine, as demonstrated in the previous photo, then usually it's just an issue with the epithelium, the outermost surface layer of the cornea. And this diagram here just shows you the different layers of the cornea. So from outside to in, the outer layer is the epithelium, and then in the middle, as I said, this is the stroma, the thickest layer of the cornea. It can only respond in one way to any sort of insult, and it responds by just turning opaque. So if you see an opaque cornea, it's no good. Yeah. So the next thing is, so we'll go back to where we applied fluorescein. If there's no corneal staining, then the next thing to look at actually is the pupils. So then if you see that the pupil on the affected red eye is larger, is there any sort of diagnosis that you might be worried about? Yeah. Myasthenia is a complex condition actually. Normally it doesn't affect strangely enough, even though it affects the neuromuscular junction and muscles, it doesn't actually affect the pupils, the iris themselves actually. So so the condition here is actually, so I'm just showing you things that you shouldn't miss in A&E or in GP, is that if the pupil is bigger, then you must always think of acute angle closure glaucoma, which is an ophthalmic emergency. This is a condition where the pressure is extremely high, and the patient will be in a lot of pain. Usually they'll be unwell to the point where they're constantly vomiting. And indeed, actually, a lot of these patients get misdiagnosed as having appendicitis because they get such a strong ocular vagal response. So they often get misdiagnosed, and it's not until someone looks at the eye and say, "Oh, actually, there's a red eye where the pupil is a bit dilated." So when you see someone with a unilateral red eye where the pupil is much bigger, you must think about acute angle closure glaucoma. And if you have to take anything from this algorithm and just get one thing right, I'll be happy if you get this right, yeah, because this is a potentially blinding disease, yeah. So then if the pupil's smaller or same size, then then the other conditions to also think about. So if the pupil's smaller and the patient's having profound light sensitivity, does anyone know what sort of condition that we might be worried about? No? Okay. So so the thing that we'll be worried about is iritis, or we also call it anterior uveitis. So this is it's a condition where classically the pupil is smaller and the eye itself is red, and the redness is usually what we call perilimbal or circumcorneal. It's just around the cornea here, and the patient is extremely photophobic. Yeah, so you don't get that many conditions that can cause photophobia in ophthalmology. So the two structures that contribute to light sensitivity is only the cornea and the iris. So if you get a patient with true photophobia where they come in, they'll be wearing sunglasses, then you always have to think of whether this is iritis or whether this is a corneal issue. But in this case, so this is iritis. If the patient doesn't have photophobia, light sensitivity, then ask the patient, is the eye really painful? Because if it's really painful to the point where the patient's waking up, at night, and they describe it like a tooth pain, then you have to think about something more sinister as well, like scleritis. Yeah. Usually you see that in the context of connective tissue disease like rheumatoid arthritis. If the eye is not painful, the patient is relatively comfortable, and the pain is bearable. Then it's the sort of benign version of scleritis, episcleritis, and episcleritis here is the only sort of diagnosis that is non-urgent. Yeah. Okay. So that's the red eye. I know there's quite a lot of information to take in, but hopefully that will just make a bit more sense. Yeah. And don't worry, I'll send you guys these algorithms as well in nice PDF versions so that you can look at it if you want. Yeah. So Lily here asks, why does the pupil dilate? That's a very good question, actually. So the reason the pupil dilates is that because the main driving factor in acute angle closure glaucoma is that there is a buildup of aqueous, or the fluid in the eye, and there's nowhere for the fluid to drain. So what happens is that the pressure spikes, increases dramatically, and when the pressure is really high in the eye, that causes sort of damage to the iris sphincters. So because of that damage, the pupil then dilates. When you see a dilated pupil, it means that it's pretty far. You're pretty far down, glaucoma, the glaucoma pathway, and the more dilated the eye is, usually the poorer the prognosis. Yeah, but that's a good question, Lily. Yeah. So, okay, so the next algorithm here, just quickly talk you through this, is the visual loss here, because this is another very, very common presenting complaint by patients. So the key step in visual loss is to do a confrontation visual field test when you see them in A&E or GP. And the first thing you want to know, again, like I said, we are sort of obsessed in ophthalmology to know whether it's one eye or two eyes. So the key question is to know whether or not it is monocular or whether it's binocular. As we've previously mentioned, when it's monocular, you can be certain that it's in front of the optic chiasm. And when it's binocular, it's from the chiasm all the way back to the occipital cortex. Yeah. So if it's binocular, then the next thing to ask and also to know is the pattern of field loss. So here in this example, I think we've already done this already. You can see here a homonymous left-sided, homonymous hemianopia. So then you know that you can localize the lesion. It will be sort of post-chiasmal. So in this case, above the picture here, you can see that on this axial CT scan, there is a hypodense area in the right occipital cortex. So because the lesion is the right side, it gives you a left-sided homonymous hemianopia. So then the next one is a bitemporal. We've already gone through this. So again, here I'm showing you on the sagittal MRI scan. You can see a hyperintense lesion in the pituitary adenoma, pituitary area, highlighting a pituitary adenoma. And here and the visual field defect here will be a bitemporal hemianopia. So when you see, if you detect anything gross on confrontation visual field, that usually indicates quite a significant pathology. So these patients should always get a scan, at the bare minimum a CT scan to rule out any acute intracranial pathology. Yeah. Okay. So as ophthalmology, we are more interested in the monocular visual field defect because that's more to do with the eye itself. When we're faced with monocular visual field defect, the first thing we want to know is what the visual acuity is, if it's good or it's bad. If it's normal, then normally the issue is with the peripheral retina. The reason for normal visual acuity here is because the macula, which is in the center here, is responsible for most of your visual acuity. So if this area is unaffected, but this area is affected, the peripheral retina, then you would get a visual field defect, usually sort of a peripheral visual field defect here. If the visual acuity is reduced, then remember, as we've said, if the vision is not 6/6, you should always repeat that with a pinhole and repeat the visual acuity. If the visual acuity improves with pinhole, then again, as we've mentioned, you'll be reassured that this is just a refractive error. If it doesn't improve and it still stays reduced, then the next thing to do would be to test for an RPD. And because by doing the RPD, by knowing that there's a RPD present, then you can localize again to exactly where the problem is. As we've also mentioned before, if there is an RPD, there's only two things that can cause an RPD, the optic nerve or the retina. Yeah. So as I've said here, if the RPD is present, then try your best. As I said, this is not mandatory, but try your best to find an ophthalmoscope and to look at the fundus. If the retina is grossly abnormal, as in this case, as this picture here, you can see that one of the vein is occluded, causing a bit of blood to spill into the retina. So this is a vein occlusion. So if you see a grossly abnormal retina and there's an RPD, then you know that the problem is with the retina. If the retina is normal, then obviously the problem will be in the optic nerve. So in this case, I've just shown you a picture here showing a glaucoma where the nerve appears to be cupped, and you will see this clinically by a large cupped disc ratio, the cup referring to the sort of central hole here, and the disc refers to the outer circle. So when this ratio is approaching 1, that's not a good sign. Yeah. So if there is no RIPD, then again, you should try to look at the fundus. If the retina is sort of, if you get a good view of the retina, but then there is an obvious problem in the macula, then you can be certain that the issue is from the macula here. And in this case here, I'm just showing the picture here. This is a age-related macular degeneration where you get sort of drusen-like deposits in the macula, causing deterioration in vision. You classically see this in the older population, where about 10% of people have them. If there is no good view of the retina, then you have to think about opacity of the media. So this usually can either be in the vitreous. So in this case, I've shown you a picture where there is vitreous hemorrhage, where usually the patient will tell you that the vision has just suddenly disappeared. So if the patient comes in sun loss of vision, think about vitreous hemorrhage. And the other condition that can cause this is retinal detachment. If it's a more of a gradual loss of vision, then always think of cataracts. Yeah. Okay, so how's everyone doing? The last thing here, I think I've got one more algorithm, just double vision. Is everyone still okay for me to go ahead? Yeah, okay. So I promise this will be the last one. So Amy asked the questions, what about loss of vision totally due to central retinal artery occlusion? That's a good question. So I'll just quickly go back to the algorithm, Amy. So you've asked about central retinal artery occlusion. So central retinal artery occlusion would fall under this pathway, because when you do the fundoscopy, the retina itself will definitely look abnormal. And because the central retinal artery is affected, the majority of the retina will be affected, and hence it will give you an RAPD. So remember, as I think that the only two structures in the eye, when affected, will give you an RAPD. Number one is the optic nerve, and number two is the retina. Only when it's widespread retinal, when it's a widespread retinal issue. So yes, central retinal artery occlusion would fall underneath this here in this part. So the last one is double vision diplopia. So this one is actually quite important because it has life or death sort of implications sometimes, if especially in a sort of third nerve, the context of a third nerve palsy. So to start off again, the thing we like to ask is actually we like to clarify with the patient whether or not what they're experiencing is truly double vision, whether they're seeing two separate images or whether it's just really blurred vision. So if it's just blurred vision, patients saying that things are actually just sort of a bit hazy and not really splitting into two, then you can just revert back to the visual loss algorithm, because it could just be a cataract. But if the patient's actually telling you that it's really two images either side by side or one on top of the other, then then that is diplopia. So then the next thing to do is you should ask the patient to cover one eye and ask them if the double vision is still there. If it's still there, despite them covering one eye, then we would say that that's monocular diplopia. And when we see that, when we know that a patient has monocular diplopia, we can instantly take a sigh of relief, and we know that this is nothing serious, because usually it's just due to some sort of media opacity, and in this case a cataract. So if the patient tells you that they can see double vision even with one eye closed, that there is almost certainly nothing serious. But if the patient then tells you that no, actually with one eye shut, they don't see double vision, so then that is a binocular diplopia, where they get double vision only when both eyes are open. So then you want to know how the two images are separated. So the patient can either tell you that it's purely horizontal, so the image classically will be side by side. And in this case, usually there are only two conditions that can give you this sort of presentation. So a good way to differentiate this is to get the patient to look to the side that makes the double vision worse. And if they look in So just before I show you the two conditions, can anyone sort of guess, in the chat, that what conditions can give you horizontal diplopia? No? Okay. So the first one, which is important to pick up, is the sixth nerve palsy. So when you get the patient to look to the side that is worse, what happens is that the eye will appear to be converging. And the reason is because so in this case, the problem is with the right eye. So there is a right sixth nerve palsy here. So because of that, the sixth nerve innervates the lateral rectus. So if the lateral rectus doesn't work, this eye is not able to AB duct, so not able to bring the eye out. So this patient here is actually trying to look to his right. So the right eye here is not, AB ducting, it's not going out, but the left is. So when this patient looks to the right, the eyes will appears to be converging, and that's where the double vision is worse. Because if this patient tries to look to his left this way, both eyes will be able to do so because there's no weakness of the lateral rectus on the left side. So sixth nerve is very important because this could be a sign of raised intracranial pressure, causing what we typically associate as a false localizing sign. So if you see a sixth nerve palsy, the important thing to do is to get a scan and just to make sure that there is no intracranial pathology. So the other thing is that if the eyes diverge when you get them to look at where the double vision is worse, then the other condition to think about is internuclear ophthalmoplegia. This is much rarer, and usually you see this in the context of multiple sclerosis. So the problem here lies in a specific pathway where the AD duction of the affected eye doesn't function properly. So in this case, the patient here is instructed to look to her left. So the left eye here is functioning properly, but in the right eye, the eye is unable to AD duct, so unable to look inwards. And this is where the double vision is worse. So this patient here appears to be sort of diverging the eyes. So when this happens, then you can sort of confidently localize and name this as an internuclear ophthalmoplegia. And usually, like I said, we see this in the context of multiple sclerosis. So the management is pretty much the same. So if you see an eye that is diverging or converging, then important thing to consider is neuroimaging, because in the context of MS, it will be important to look for any sort of periventricular white matter lesions, as well as the other signs of systemic signs of multiple sclerosis. So coming back to how the two images are separated, we're nearly done. So if the images are separated vertically or obliquely, then we have to think of sort of other cranial nerves. So anyone want to name me? So what are the cranial nerves we've not mentioned? Sorry, Soma, I've just seen your answer there. Yeah, you're absolutely correct. Yeah, so it's an internuclear ophthalmoplegia. Fourth, yes, correct, Amy. Anything else? What are the cranial nerves we've not mentioned here? So we've mentioned six. Fourth, you've mentioned that as well. What's the other one? What's the most important one that you need to not ever miss in A&E? Yes, a third nerve. That's correct, Alex. Yeah. So when patients tell you that there is vertical diplopia, the next thing that you have to assess is the patient's pupil and also the patient's eyelid, because by looking at the pupil, that gives you a lot of information. So if the pupil and the eyelid is involved, then we get really twitchy, because then that points towards a problem with the third nerve. So in this picture here, I've written anisocoria, so unequal pupil size or ptosis present. So if you see that, so in this case, the patient's right eye, there is a full ptosis. So without manually lifting the eyelid, the patient, has a full ptosis here. And if you lift the eyelid, it is very likely that the pupil will be dilated compared to this left eye here. And also classically in the textbook, they say that the eye is sort of down and out in a third nerve palsy. But in real life, these patients typically don't present in this manner. Usually they sort of get a combination of pupil and lid signs, or they can get an incomplete third nerve palsy. But the important thing to say is that I know in medical school, we are taught to sort of try to differentiate it on the basis of whether this is a medical or surgical third nerve, or whether or not the pupil's involved. But the guideline now is that in any form of third nerve, the patients should get a scan because you cannot rule out, involvement of the posterior communicating artery aneurysm on the basis of whether or not the pupil is involved. So if you see a sort of slight ptosis, but the eye is the patient's complaining of vertical double vision, and the eye is slightly down and out, but the pupil is not dilated, you should still scan these patients. So that's the take-home message here. And then I just want to see, so Amy, and then you can see upon manual lifting of the eye, you can see that pupil, you can just barely make out that pupil is down and out actually, and also dilated there. So in this case, this patient needs an urgent CT angiogram to check for any PCOM aneurysm. So then if the pupil and the lid are not involved, then we are usually a bit more relaxed. Then you can, so then, you sort of know actually, so this is not really a third nerve. So there's certain conditions that can give you vertical double vision. So the first one here I put is thyroid eye disease, because just remember in ophthalmology, the great mimicker is thyroid Graves' disease, because it can give you any sort of pattern of double vision. So if this patient comes to you with the classic signs of Graves, where the eye is sort of proptose, the eyelid is retracted, the patient's got a sort of starry appearance, and the patient's complaining of double vision, then it is likely to be thyroid eye disease, and you should investigate for any sort of systemic complications, and as well as doing a full sort of thyroid function test. And then I think so in this case here, so let me just have a look at the picture. So the picture at the top is showing patient looking in primary gaze or looking straight ahead. And in the bottom picture here is showing that the patient is attempting to look upwards. So actually on the right side, the eye is not able to elevate. And the reason for this is because the inferior rectus here, which is responsible for depressing or pulling the eye down, is restricted, is tight because of the thyroid eye disease. Yeah. So the last condition here is, I think Amy has mentioned this, is cranial nerve 4 palsy. And this is usually a diagnosis of exclusion. So if you've excluded everything and the patient's still complaining of sort of double vision, vertical double vision, then think about cranial nerve 4 palsy. Yeah. So I think that's it. So hopefully by the end of all of this, I'm hoping that we have addressed them over the last couple of slides, and hope that you've learned something useful. So thank you for listening. This is the QR code. If you want the algorithms, feel free to just scan this and you can get the algorithms. And the algorithms will also include the other common eye symptoms that I've not described.
Lovely. Thank you, Peng. That was a very informative lecture, and it was very comprehensive as well. And I'm sure we've all gained a much better idea of the kind of things to include when we're making referrals or when we suspect an eye pathology happening. I'm just going to copy the feedback link into the chat face. If you could all just fill in this feedback, it would be very valuable for both the Mind the Bleep team and for Dr. Peng as well. And thank you very much. I hope you guys all found that lecture to be very helpful, and Thank you again, Peng.
No, thank you. Yeah.
It's been a pleasure to have you here.
Yeah, thank you. Thank you very much. Yeah.
Lovely. And if anyone has any questions as well.
Yeah, I'll stay around for a few minutes. Yeah, if there's any questions.
Just type it into the chat.
So I've seen some questions here. ICP be a differential? Yes, Alex. So ICP is definitely a differential that you should always consider. I think you're referring this to the presence of a sixth nerve palsy. Yes, so always think of ICP because that is potentially life-threatening. So you should always think about raised ICP in a sixth nerve, yeah, and always scan these patients.
Lovely.
Yeah, so yeah, feel free to just take a screenshot or anything if you need the algorithms. Yeah.
Perfect. Well, thank you. And we'll also I'll take a screenshot of this and we'll send it out with the emails for the attendees as well.
Yeah. Thank you so much. Yeah.
Lovely. Thank you again. It was
Have a wonderful evening, everyone. Yeah. Take care. Bye-bye. Okay.